Good morning, everyone. So I'll be taking the few questions which sir presented plasma exchange, what are the literature about it and everything. So I'll start with basics. So I'll be talking about acute liver failure. It's a race against the necrosis of the liver. The turning point between acute liver injury and acute liver failure is hepatic encephalopathy, as we all know. And the spectrum can be hyperacute, which is within 7 days. 7 to 21 days is acute, and subacute is more than 21. But it is based on etiology as well. Generally, acetaminophen, paracetamol causes hyperacutes. Viral etiology is acute, which we see in more common, and subacute like DILI and indeterminate. And in ALF, the main thing also is etiology. In Western part of the world, acetaminophen is most common, so the Western literature does not always apply to the Indian population. In our part of the world, viral etiologies and now DILIs are also very common. So when a patient meets criteria of INR more than 1.5 and encephalopathy, we do a tox screen for paracetamol, viral screen for hepatitis A, B, hepatitis E, and then we have also to be checked for Budd-Chiari autoimmune cerebral plasmids. And we kindly do not label as indeterminate until unless the paracetamol poisoning is negative and comprehensive viral screens are negative, because there can be viruses like varicella, herpes, which can be found positive. And ALFs can present as various complications like neurological complications, infection, as we all talk, pulmonary complications very common, acute kidney injury, hemodynamic instability, and coagulopathy. And there are different prognostic scores like King's College criteria, which is very highly specific, which predicts death well, but it's very low sensitive. It misses the patient who needs a transplant. Other criteria are MELD score, which we are more familiar with because we deal with CLD patient day in and day out, but they can underestimate coagulopathy risks. And dynamic scores like ALF-SG, which includes coma, clinical condition of the patients, are complex calculations. The most important point is the dynamic trends are more important rather than the static score. In paracetamol poisoning, rapid rise in lactate. In other ALFs, rapid rise in INR should be a red flag and should be taken into account. I'll talk about brief about general management. As we all do, neurologically, head rise to 30-degree, quiet room with minimal stimulation. Metabolically, we prevent hypoglycemia, neuroprotection is done, avoid nephrotoxins, and treat vasoplegia. So I'll talk about questions one by one. This is first managing cerebral edema. The old standard was invasive intracranial monitoring, but recent literature shows risk of invasive intracranial monitoring is higher than benefit. The current standard of therapy is ammonia clearances using hypertonic saline, early CRRT or temperature control. Non-invasive monitoring like ONSDs, optic nerve sheet ultrasounds are more common. So we do not do invasive intracranial monitoring anymore. So hemostasis, as we all know, INR is high in these patients, but do they bleed? But actually, the bleeding risk is not high with high INR because platelets are low, but there is very highly active because of von Willebrand factor compensation. So we do not chase INR, we do not correct INR until unless we think there is a risk of active bleeding. There are etiological specific therapies as well in acetaminophen and acetylcysteine. Time dependent and acetylcysteine is important. In optic hepatitis, steroids have been tried, but it should not be given for more than 7 days if there is no response. And in herpes, HSVs, acyclovir, mushroom poisoning, penicillin G, and pregnancies, delivery health. So these are etiological based medical therapies. So now the question is, when hepatocyte necrosis happen, it leads to cytokine storm. And there are various liver assist devices, as we'll talk about therapeutic plasma exchange, CRRTs, and MARS, which can theoretically lead to decrease in this cytokine storm and improvement in multi-organ failures. So we'll talk about therapeutic plasma exchange. The first literature, the biggest literature came from Larson's trial in 2016. We showed high volume plasma exchange in patients with acute liver failure, RCT. We showed benefit 58% benefit rather than 47%. This is the first RCT, bigger RCT we showed liver support system shows a survival benefit in RCT cohort. But when we look into literature, the plasma exchange is not replacing transplant. If we see the subgroup analysis in this study, patients which are fulfilling the liver transplant criteria and receiving transplant with or without plasma exchange have better survival as compared to patients who do not get a transplant. So we have to see the literature in detail, and they have also shown the patient. This is the second graph which shows the patient who fulfilled the liver transplant criteria but did not get a transplant. The survival with although plasma exchange is better than standard medical therapy, but much poorer than if they would have got a transplant. So we should aim for transplant. We should aim for therapeutic plasma exchange as a bridge therapy, but not as a sole therapy until unless we do not have a transplant option. This is another trial by Dr. Rakhi, another RCT, standard volume plasma exchange improves outcomes in patients with acute liver failure, a randomized controlled trial, 20 patients in each arm, and they have shown the standard volume of plasma exchange shows similar survival to high volume. The plasma exchange significantly decreases pro-inflammatory cytokines, endotoxins, and DAMPs. And again, in these patients, most of the 80 to 80% patients are hyperacute liver failures, and 20 patients in each arm, with only 40% patients meeting King's College criteria. And all the patients included in the trial are patients who do not have a transplant option. So coming to the adult evidence, this is the pediatric evidence from our own institute, ILBS. This shows when you see the outline of it, 46% native liver survival as compared to 26% on with plasma exchange, with day 4 clinical impact of lowering INR, lowering bilirubin, and lowering maintaining mean arterial pressure. But is it actually true? When you delve into this same paper, we see this survival benefit is mainly limited to hepatitis A patient. In rest of the indeterminate etiology or other etiologies, the benefit is not shown. So in hepatitis A, the therapeutic plasma exchange have been shown benefit in pediatric population. So this is the paper from King's College Hospital, which shows real world discrepancy in use of plasma exchange. And they have shown there's no difference between PLEX in standard medical therapy in overall survival and transplant-free survival. And the patient who underwent transplant after PLEX, even one session of PLEX, have not shown any improvement or any improvement in hemodynamic parameter or survival. So there's a real-world discrepancy on use of therapeutic plasma exchange in ALFs. Definitely, there is a strong evidence in viral etiologies like hepatitis A and Wilson's. There is a weak evidence in acetaminophen and other DLEs. So we need to use plasma exchange carefully based on etiology as well as the clinical condition of the patient. But plasma exchange does not come without its own problems with metabolic alkalosis, sepsis, electrolyte derangement, and hemodynamic instability, which needs to be taken into account when we do plasma exchange for the patients. And the timing is also very important, because in early phase of acute liver failure, there will be SIRS, but in later phase recovery, pro-regenerate macrophage will be there. So timing of the plasma exchange is also very important. The other question which was raised is generally in recent literature is renal replacement therapy, the CRRTs. So this is the use of CRRT beyond kidney. It shows to have better ammonia clearances, better hemodynamic instability, and preserve cerebral perfusion. So this is the evidence. This is systemic review or meta-analysis published, which shows in adult population, they have compared 305 patients of CRRT and 1100 patients of standard care. And this is observational data. Although the patients in CRRT group were sicker and higher encephalopathy, but still they showed benefit. So they've showed 17% reduction in mortality and 35% decrease in reduction of transplant. After this, because of this literature, American College of Gastroenterologists and critical care guidelines have now recommended CRRTs in first-line therapy of hyperammonemia in ALFs. But we need to avoid this clinician trap. This is the line of artificial clearance of urea and creatinine, and this should be the true improvement. So we need to take into account that CRRT is being used. So this dynamic parameter, ammonia and lactate use, is not always indicator of liver recovery. So bilirubin, factor 5, and INRs needs to be taken into account. Trends in in bilirubin and factor 5 reflect true hepatic synthetic function and to be accessed on the timely regular fashions. This is a small window of opportunity. This is a small article from in JHEP in 2025. They have shown early initiation within 2 days have shown survival benefit in CRRT, but not after 4 days. So there's a very small window of opportunity which we have shown. Coming to liver transplant remains standard of care as of now for acute liver failures and its ultimate safety net. The survival has improved with the time as high as 70%. As you can see in first graph, if we delay transplant and if the transplant option is available, with each day delay in transplant, the survival benefit decreases. We have published from our own department. This is the paper published 2019, the living donor liver transplant for acute liver failure, and this is a recent published in pediatric liver transplant, which shows excellent survival outcome with liver transplant. In the second paper, although we have mentioned we saw better neurological recovery with plasma exchange, but we are not sure yet now. So the path forward is what is happening in the future in estimate poisoning. These are bedside tests. The card-sick tests can be done we don't have to wait for labs. All King's College criteria MELD are all static tests. This is 13 carbon methacin breath test. Is shown to be real-time metabolic function, but it has not been validated in all the cohorts. And then this ALF study group prognostic index, which is a dynamic score which can predict 21-day survival. So immune response can be both friend and a foe. Immunomodulation can be one of the things which can change the game for acute liver failures. Then again, it's a race against regeneration. If the regeneration is better, then the liver survives. So there's therapies which can actively stimulate regeneration, like WNT agonists, which are being studied recently. And then again, apoptosis, there are therapies blocking specific cell death apoptosis, which are being studied. The literature is yet to come. And then last in this extracorporeal liver support, like Mars, there are mixed results. There is a large meta-analysis for France, which showed there is no survival benefit in Mars, but there is still literature in which studies which have shown benefit with Mars. Stem cell derived hepatocytes and bioartificial devices are yet to be analyzed, and results are yet to fully come. So the future can be bedside testing in ALFs. Then it can be pharmacotherapy, WNT agonist, necrosis blockage, and until then, we have all these therapies. Transplant remains mainstay of treatment. We have to diagnose and offer transplant. If there is no transplant, then definitely medical therapies, CRRT, and plasma exchange needs to be continued. In ALF specifically, time is hepatocyte. With every losing minute, we lose hepatocytes. We have to identify early, we have to treat aggressively, and we have to bridge to life, bridge to transplant. I'll call Dr. Nilesh for technical details in ALFs.
So good morning, everybody. Because of time constraint, I will try to summarize what are the surgical challenges in ALF. Basically, in ALF, we see more sicker patients as other centers in the India, also in the worldwide. So to perform this operation at odd time, especially most of the ALF happens in the midnight, you need an expert team which has lots of experience, especially to tackle the complex anatomies and to perform operation quick but meticulously. And also it has, because the surgery, the margin of error is very small. The pre-op optimization, what we do in routine in IL-based, we usually ship the donor, we start the donor, and we open the donor and we look the quality of the liver. Meanwhile, we ship the recipient on the OT table. Sometimes while shifting, after putting the patient on the table, the ventilatory support, inotropic support increases. So we have to coordinate with the donor team. And And sometimes very sick patients who have a toxic liver syndrome, especially young guys, sometimes we have to do a two-stage procedure. It is common in DDLT scenario, even the reports from the worldwide and even from recently from the India and Hyderabad. Even the LDLT has been performed in two-stage procedure. In sick patient, you do a rapid explant, you do it with temporary portocable shunt. Observe the patient on the OT table. You try to monitor the inotops, hemodynamics. If the patient improves, the cytokine storm, that is SIRS, lessens, then you start the donor surgery and you complete the procedure in two-stage procedure. So we have to keep a watch, especially the senior member from the team. We have to coordinate with the donor team and the recipient team. As previously discussed, the most important point is the continuation of the intra-op CRRT. You have to take into account the risks and benefits, as especially in sick patients with toxic liver syndrome, which are in grade 3-4 HE, the pre-op CT showing cerebral edema, it is better to continue the intra-op CRRT. But which are the stable patients, because intra-op CRRT has its own limitations, that is, especially in childs, it leads to hypothermia, which can worsen the coagulopathy. Intra-op CRRT can increase the bleeding complication. The most important is the intracranial bleed. Sometimes the tube king malfunction, it can thrombocytopenia, hemolysis, even the prolonged, because of the prolonged CRRT pre-op, intra-op, it can lead to even hypophosphatemia, which can worsen the new liver regeneration. So we have to balance the risk and benefits to continue the intra-op CRRT. And the surgeon has to be vigilant whenever the patient has developed hypothermia and coagulopathy worsened. You have to see the surgical field. You always put a good communication with your anesthesia colleagues. You have time constraint. It is not like elective operation. You do slowly, but because patient is rapidly deteriorating, you have to be quick, but still you have to meticulous to perform this operation. Because of this SIRS, usually they have third spacing, the edematous tissues and the inflamed tissues. So to manipulation of the tissue should be very meticulous. Next, the important point is the working space constraint. Especially we see the young male donors, they have narrow costal arch. We have to plan the incision. Usually we perform the operation with reversal incision, but sometimes we have abdominal wall edema, distended bowel loops. So we have to do a classical Mercedes Benz incision to have a proper exposure. Sometimes because of the lactulose effect, the large, especially the transverse colon has hugely distended, the edematous mesentery. So to have a better exposure of the hilum and the liver, we bring the transverse colon out of the incision and cover with the warm saline mops. So have a better exposure. That's why we repeatedly request to our both adult and pediatric hepatology colleagues not to give a lactulose in the preoperative optimization. So next part is you have to perform the native liver explant with quick, and we have to do a cable preservation. Usually do a high hilar dissection, that is because in LDLT, the inflows and outflows, the length of the arteries and the portal lamens is short. To have adequate length on the recipient side, we do a high hilar dissection. That means we dissect the arteries as possible in the hilum beyond the bifurcation of the left and the right hepatic artery. Well, because the tissues are inflamed and edematous, usually they have preoperative on the prolonged, they have multiple on CRRT, plasmapheresis. Chances of arterial dissection very high. You have to handle should not negate the arteries. You always, because we see always the two large lymphatics run along the artery. We manipulate the arteries with that lymphatics, and also should not put the ligature or clips too tight on the arteries. That can fracture the intima and can lead to dissection. Because if the arterial dissection happens, the surgery is happening odd time, it will be the nightmare for the surgeon to manage that arterial dissection. So we divide the bile duct as high as possible. Sometimes you get multiple ducts on the donor side. So we divide the bile duct above the portal bifurcation. We lengthen the portal main proximally, and we take the right and the left. I will show in the video. We usually take the right and left portal vein separately, because sometimes usually the distance between the portal vein and the IVC is 1 to 2 centimeter. But because of the SIRS tissue edema, that distance increases, and while making a shunt, sometimes the portal vein doesn't reach to the cava. So we have to have adequate length to form a good shunt. So you do your early shunt to prevent the toxic liver syndrome, and then we mobilize the liver. We, after opening the abdomen, we do not manipulate the liver much unless after hilar dissection and after formation of the shunt only we mobilize the liver. First, we mobilize the caudate from the cava and the rest of the liver from the diaphragmatic attachments. Especially mobilizing the caudate, sometimes though they are normal livers, sometimes they have complete caudate wrap around the IVC because tissues are inflamed, the planes are not good. Chances of caval injury are very high. So you try to perform it meticulously because any hemodynamic instability will leads to worsening of the brain damage. Next part is the meticulous benching. That is very important, especially usually in the small kids up to 20 kg, the left lateral graft is sufficient, and more that we take a left lobe grafts, and adults we take a right lobe grafts. Especially in the right lobe grafts, we usually to have the functionality of all the graft to improve, we drain the anterior sector properly. We are already published. That is, we recreate the new MHU with a PTFE, and we reconnect the PTFE to the RHV to have a wide opening outflow. In left hemigraph grafts on the pre-op CT, sometimes we get a MHV, LHV, the separate opening. You have to have wide outflow to have at least 4 to 6 centimeters. Sometimes you do a septoplasty or you do a unification combined venoplasty. Sometimes you widen the opening. We get a superficial hepatic vein on the left side grafts of phrenic veins. We extend the opening over the phrenic veins of the superficial veins. We keep cold ischemia short and warm ischemia as previously discussed. The prolonged cold ischemia time is a predictor of the post-transplant death. So always coordinate with the donor team to have a minimum cold ischemia time and the warm ischemia time. Especially we try to avoid because this is odd time surgery, emergency or complex operation. We try to avoid the complex anatomy in initial part. But as expertise increase, even you can tackle the complex anatomy, especially the multiple inferior veins, because putting a multiple clamps on the cava is equivalent to the cross clamp. So we try to take a simple anatomy to have quick, safe operation. Usually the reperfusion happens with sequential anastomosis. We do first the outflow reconstruction to have wide outflow. It depends on the it depends upon we have to different plans for the different patients, especially patients who have toxic liver syndrome usually have distended bowel loops, lots of tissue edema. So we first reconstruct the outflow, and after that we dismantle the temporary portocaval shunt. Otherwise, sometimes the graft has, especially the right lobe graft, which has multiple inferiors. We need a side clamp on the cava. So and the patient, there is no much tissue edema, no distended bowel loops. We dismantle the TPCS initially only before reconstruction of the outflow. So you have to individualize your plan according to the patient. And we try to avoid the cross-clumping of any cross-clumping will lead to hemodynamic instability. We try to avoid that. All inferior hepatic veins we reconstruct, especially which are more than half a centimeter in size. Even the proper implantation of the inferior hepatic vein gives the proper position of the graft in the abdominal cavity. And portovein, after that, portovein reperfusion is performed. After reperfusion, especially in the large grafts, we have tissue edema, we have prior toxic liver syndrome, they have to prone for the reperfusion syndrome. So during reperfusion, at least you made the head position, you try to make a neutral or slightly head low to avoid the cerebral hypoperfusion. After that, we perform the hepatic artery anastomosis, which is usually done end-to-end with the interrupted anastomosis with eversion technique. And after that, we do a Doppler to confirmation of inflow and outflow. And after that, we do a bile duct. Bile duct, we try to prefer to ductal duct anastomosis because in this patient doing HJ is not a straightforward because the edematous tissue to making a window in the colon and to make attaching edematous bowel to the bile duct, chances of bile leak are very high. That's why we do divide the bile duct always above the portal vein bifurcation to have multiple openings. Even the multiple bile ducts come on the graft side, we can do a multimillary anastomosis. It is a basic all vascular anastomosis. We have tension-free anastomosis. It should be anatomically correct orientation. Try to avoid any kinks, redundancy, or torsion. We should have widely patent lumen. Should not put all the knots very tight to prevent the narrowing of the opening. Sometimes there are two portal veins on the donor side. We have to put a venous patch between the two portal veins, and in especially portal vein, we try to put a growth factor almost 1 to 1.5 times the diameter of the donor portal vein to expand the portal vein and to avoid the postoperative narrowing. The suture line should be hemostatic and it should be carefully taken. Usually their tissues are inflamed and edematous to avoid intimal injuries, which can lead to post-transplant thrombosis and thrombotic events. But during the anastomosis, always tell your nursing colleagues to have regular flushing the anastomotic site to remove any clots. And you should avoid overcorrection of the coagulopathy. Always do a tech-based correction and also to a surgical field to do a correction of coagulopathy to avoid thrombotic events. We arterial anastomosis and biliary anastomosis, we follow the standard techniques which has been published, that the arterial anastomosis do a clockwise suturing technique. We start from the one end and we usually put intima to intima approximation and try to always take a needle bite from the inside, avoid with meticulously avoid intimal injuries, and should not tie the too tight to avoid the narrowing of the arterial lumen. Biliary anastomosis also is done with all not outside technique with mucosa approximation with watertight closure. Most important part is the surgical hemostasis, because especially this is odd time surgery, the all team is tired. So we, after biliary anastomosis, we try to take a break, freshen up 10 minutes, and after that with a cool mind, we do a surgical hemostasis. Some of the important areas we always look, that is a retractable area where the bleed from the small veins can be disastrous, especially the adrenals, phrenic veins, and the most important, the drain sites. Next important point, the graft fixation, especially the left-sided grafts we implant in the midline. So we have to fix the grafts to avoid the torsion of the outflow. And the abdomen closure, I told previously, because sometimes the bowel edema is that much, we can't close the abdomen, which can lead to a compartment syndrome with other extrahepatic organ dysfunction like kidney and lungs. So sometimes we have to do a Bogota closure to have a safe operation. I remember one child which has a huge abdominal distension. We're not able to close the abdomen. We have put the Bogota duct. That child underwent almost 5 to 6 times re-exploration post-transplant. That's why we request our colleagues to try to avoid the lactulose in pre-transplant setting, because obviously that increases the financial burden and utilization of the hospital resources also. So prevention is always better than the cure. Most important is shifting the patient. It is not just the transferring the responsibility to your anesthesia colleagues. The seniors, surgical team member always go with the patient while shifting the patient from the OR to the IC. It should be a detailed handover. There should not be any communication gaps. While shifting, you should look after the portal ventilators, try to avoid hypercapnia, maintain the head and elevation to avoid sudden mishaps. Adequate sedation, analgesia, muscle paralysis to avoid the bucking and sudden coughing of the patient. Care of the all vascular access, especially vasopressor infusion to avoid any cardiac instability, and especially for surgeons to look the drains, they should not get caught sometimes and get accidentally removed while shifting. And decision to continue CRRT, it depends on the individualized case-to-case basis, especially patients who are severely sick, especially the
Sorry, Nilesh, to interrupt you. It's a beautiful thing. Are you summarizing or?
Yeah, I just finished, sir. Next
you
video.
Finished?
So, morning, everyone. Very nice presentations from Nilesh, Nihar, and Sahil. Well done, guys. Sahil, the slides were very good, actually. Really liked it. So, what I'm going to do is I'm just going to touch on this contentious issue of how to select patient for liver transplantation in acute liver failure. And I think this is the crux, actually, which makes most of the difference what happens to this patient. So this is, you've seen this slide before. So we are now almost touching 1,400 transplant, and we've done more than 200 pediatric transplants as well. And these are the outcome. And when we look at the outcome, the outcome is shown by Nihar as well. So this is now ALF is 133. So the crux here is this is the perioperative mortality which is making a difference. And this is just because how sick the patient were before they were taken up for transplant. And can we improve on this front in order to have better outcome? Because this is a huge effort. Transplanting ALFs and ACLF requires a lot of effort, requires a lot of resources, and also a huge financial burden for the hospital and for the patients as well. Because patients are in package, so you don't really realize how much actually expenses can escalate in this type of patients. Okay, so how we can do it? So when we look at our mortality, So sepsis and multi-organ dysfunction, diffuse cerebral edema with brainstem death, and diffuse cerebral edema with intracranial hemorrhage and alveolar hemorrhage as well, intrapulmonary hemorrhage. So these have been the major killers after the operation. So how we can improve on this? This is about, most of this is coming before the operation. These are not the things which have happened during the operation or after the operation, after the new liver has come in. These are factors which have been playing before the operation, and can we get better on this? And when we look at the multivariable analysis, it is persistence of cerebral edema and SIRS and positive cultures, which are the one which are playing part in terms of perioperative mortality as well. And why we are having this problem? The problem is because we are following a King's College criteria in selecting patients for liver transplantation. This is not good for us. This is not meant for our patient. This was meant for patients in UK or Western patient. This was never meant for Indian patient. And we need to realize this strongly in order to improve this outcome. So KCC was derived for West. Presentation and etiology is very different in India. Indian patients have a very different presentation for ALF. KCC can detect patient with poor prognosis, but it's not accurate in predicting that everyone who doesn't fulfill the criteria will survive. So it can just tell you that patient who fulfill the criteria, they've got a very high probability of dying. But the patient who does not fulfill the criteria, it doesn't guarantee that those patients will survive with native liver. And that's the biggest actually problem with KCC. And we need to realize this. So even in the best centers, even who doesn't satisfy criteria, 50 to 60% die if they have SIRS, sepsis, and cerebral edema. So there is a high specificity here, but a very low sensitivity in terms of selecting patient for transplantation. And what are the problems for KCC? It is about, basically there are four most important factors which play part in terms of what the outcome of patient is going to be. It is severity of cerebral edema, SIRS, sepsis, other organ dysfunction, and hemodynamic instability. And these are all which are not part of KCC as a criteria for selecting patient for transplantation. So one has to realize this. This is the most important thing, because factors which are actually killing patient are not part of the criteria for which you're selecting a patient for a treatment modality. That's what the difference makes in. So when you look at acute liver failure, when it is hepatitis, it is about hepatocyte injury and hepatocyte repair. So that's a balance there. When basically injury is more than regeneration, then it is failure. And when you have a necrotic liver, it actually excites in terms of SIRS, sepsis, cerebral edema, and multi-organ dysfunction and failure. But that's where the bad news comes in terms of what will happen to the patient later on. And when we look at the mortality driving factor, this is cerebral edema and SIRS sepsis, which are actually entangled together. They actually enhance one another. Once you have SIRS sepsis, there is high risk of developing cerebral edema. And if you have cerebral edema, then there is a high risk of developing SIRS and sepsis as well. And what are the factors which precipitate this? This is again, it can depend on etiology. If you have an infective etiology, high necrotic liver, it will have cytokine storm. Then you have gut failure leading to translocation. Then you have respiratory problems, mechanical ventilation, infection, TRALI associated with plasmapheresis and CRRT as well. Then again, cerebral edema will lead to SIRS and sepsis as well, fluid overload and uremia. So all this actually contributes. So these are some of the things why I put in this slide here is there are few of these things which we do in ICU, which can actually precipitate SIRS and cerebral edema and actually be a counterproductive for us. So we need to be careful when we manage this patient in ICU that we are not harming patient rather than doing good. We're not harming patient by doing more things which are not required for the patient. And that's, I think, very good, very big message we need to keep in mind when we manage this patient in ICU as well. So again, this is again just to put that thing, that criteria for liver transplantation are based on hepatic encephalopathy, bilirubin, INR, ammonia, and lactate, whereas the outcome is dependent on cerebral edema, SIRS, sepsis, hemodynamic instability, and hepatic organ dysfunction. So this is our etiology. This is very different from West. West doesn't get this etiology. 36% is hepatitis A, and then undetermined is 44%. Most of this is basically we don't have tests to know why this has happened. That's why it is undetermined. So this doesn't happen in West. And this etiology is especially undetermined, behaves very differently than what the patients are seen in West. So we need to be very clear about this. Then we see a lot of ATTs as well there, which have again worse prognosis as well. Then there is a common belief that hyperacute presentation is associated with good prognosis. Hyperacute is basically within 7 days. Jaundice to encephalopathy period is less than 7 days. But when you look at, and then when you combine with etiology, again, the mortality in this group of patients remains high, in spite of having hepatitis E and hepatitis A. So hyperacute doesn't always mean that they will survive with native liver. There is a group of patients who will still do bad, and they need to be selected for patient for transplantation as well. So this is again the data from the literature, and you can see if you have grade 3-4 cerebral edema, irrespective of other factors, the mortality actually goes beyond 70%. So that's one triggering factor when you have a patient in ICU, irrespective of bilirubin, INR, and other factors who have cerebral edema. There is a high risk that they may not survive without transplantation. And these are patients who need to be assessed very quickly for transplantation as well. Again, this is our own data, and you see the criteria, because again, I'm coming back to criteria again and again. And you see, even patients who are not satisfying criteria, 1 in 4 die when they are not satisfying any of the King's College criteria. Then if they satisfy 1, it is 44%, 2, 57%, 3, 62%. And if you have a single criteria, INR more than 6.5, the mortality is beyond 80% as well. So this is an important thing. You can't beat these numbers. These numbers are very important to remember in order to select patient for transplantation as well. And again, as I emphasize, hyperacute doesn't mean that everybody is going to survive. So this is just to summarize that how to select patient. So you need to look at severity of cerebral edema, sepsis, organ dysfunction, hemodynamic instability, not just the criterias. And this we have talked about in the whole ground round. So I'm not going to go again through this. And these are 2 important papers which we have published. I hope everybody should read this, because don't just go with the abstract or the title of the paper. Just read everything in this paper. This is a very important publication, and that will tell you exactly what is happening to Indian patients in acute liver failure. So there's good. Good is when you a transplant patient survives, it's very good. Bad is you delay the transplant unnecessarily, and then you have to have put a lot of resources into it in order to get an outcome. And the ugly is the patient has been delayed too much that it becomes a futile transplantation as well. So thank you very much. Thanks a lot.